Everyone. We are going to go ahead and start. So first we'll start with the tilawat from Holy Quran. Please.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين
Ameen. Jazakallah. Okay, let's start with the national anthem, please. Please stand up for the national anthem. Thank you very much. On behalf of course directors, Council of Pakistan Society of International Cardiology, I would like to welcome you all. I hope with time we will have more people over here. I think we are really excited this year with the new program, a lot of new things, and one of them is really this structural heart interventions. And that was basically based on because there was a lot of enthusiasm from our young colleagues as well as senior cardiologists who really wanted to have this kind of session on structural heart program. So that's why we basically devised this program. And I would really like to thank today's moderators who are, I think, very well known and eminent, not only cardiologists, but structural interventionalists also, who put in a lot of effort to really gather world-class faculty to give the talks today. And I'm sure, I think all of us are really going to learn a lot from these talks from the experts from all over the world. And I'm so grateful to these international faculty. Especially most of them are in US and it's a very early morning there, and they agreed to really participate in this meeting, and they'll be giving these talks. So I would like to first invite the moderators who will come up here, and they will be running the program, and then they will call the panelists. We again have also excellent panelists from here as well as on Zoom who will be able to discuss and give us their opinions, and we'll learn from all of them as well. So I would like to request Dr. Asad Akbar Khan, Dr. Usman Mustafa, and Dr. Ali Raza to come up here and please moderate the session and take from here onwards. Thank you very much.
Bismillah ar-Rahman ar-Rahim. Thank you so much, Bashir Neef Saab and everyone. And it was an honor to present and start this moderator session. Our first speaker is Mr. Vijay Tehran, and he's going to be talking about tips and tricks of PTMC, one of the very common problems in towards the India and Pakistan region. And I'm sure I'm going to learn a lot from him being trained outside. We were all TOE guided exposure to the PTMC. So I would check if he's ready for us to start his session. While we are getting ready for that, I would like to call on stage the chairpersons. Please kindly, whoever knows about it, but I will call their names as well. We have got Mohammed Raza, but I think he's going to be online from USA. Wasif Qureshi from USA. Mubashir Mumtaz from USA. Parvez Mehraj from USA. And Ramesh from USA. Asad Patan is, I can see, probably he's going to join us as well. And Tahir Saghir Saab, Abdul Hakim, Farkad Alamgir, Mohammad Irfan Saab, Tariq Abbas, and Noman Nasir. Please, whoever is available, please kindly join us on stage. Tahir Saghir Saab, I think please join us on stage as well. I think Vijay Tehran is ready to join us, and then we'll see, request our team to get him online, please.
I'm already online. Am I audible to you? Am I audible to you?
Yeah. Thank you so much for joining us today, and welcome for our first session. I would introduce Vijay Tehran as well. He's a leading cardiologist for PTMC, and he's going to tell us a lot of tips and tricks of the PTMC. So hopefully we'll learn quite a lot from him. Can you hear us, sir?
I can hear you loud and clear, but am I audible to you? It looks.
Yes, if you are ready, you can start your presentation, please.
Am I audible to you?
Yes, we can hear you. And we can see you as well.
So if I am audible, then I think. Sir. First of all, thanks very much to the organizers, especially Dr.
I think
Bashir.
we have got a bit of an issue here, listening to you. I think the audio is not very clear, so and we are not going to put you under pressure, but you have got only probably a few minutes to present as well. I think that's always the problem with the first.
All I should say that the better person you would be there to talk about this thing and accepted the invite and pertaining to this topic, I done 62 PCs, one day single-handed, one table. That was about a couple of decades ago.
Then I had the honor of lab without using radiation, without using chloro. Is it clear? Am I audible? The talk has to start like this. Then I had the opportunity, but without using pressing a pedal of chloro, only to pericardial sepsis. And I'm sure many of you than me. But the topic here is tips and tricks, situations when we get into trouble. I'm getting a response from that side. Am I audible to you? My net is at very high speed, 75 speed. Speed is. Am I audible now? Am I audible to the house? I can see the picture now. Is it audible?
We are struggling probably a little bit to hear you, sir, because I think it's the internet issue which is going on, but we are trying our best to catch up with you.
My speed is showing 75 Mbps. Anyhow, so what I wanted to share was that despite having tremendous experience PTMC over the last decade, is 62 just done one day. Cases being multiple times, हाथ ही निकल गया, पूछ गई, and what? And I'm sure many of you might be getting a similar kind of a drop. Shooting some time left. This is the attack they go. Know that we also horizontal and we manipulate rather than from above downward, maybe from below upward. Most often the direct cross works, but cross is a far thicker than a direct cross. And at times, if the septal puncture is dental, you might run through the stomatal valve, but with the jet which is working from L12. At times, a puncture is anterior superior and it is close to the mitral valve. And you are seeing your catheter. And this also seen in person giant left form my direct right to spring bar. It's all tape. No infrared balloon. Floated close to the hello. It is not audible. Hello. Hello.
Hello?
Hello. Yeah, Dr. Bashir. You can't listen. I don't know, some internet issue. Here the speed shown is.
We still at the Hathi Nikal Gaya slide.
My side it is speed is 80 bits. Just checking it. Screen is shared. That could be, switch it off. I can. Now the video is off. Is it audible now?
Yeah, that's better now. That's better.
That's better. So,
Sir, you have got only a couple of minutes left. I'm really sorry, but because we will be
so it
landing.
doesn't matter what. In those couple of minutes only, I'll just try to cover a few things. And I'm also getting call from Dr. Bashir. Hello. Hello. So, is it audible? Somebody tell me is it audible or not? Hello.
Yeah, we can hear you now.
Hello. So, we all know that if you have a certain distance from the mitral orifice and the usual curve of the stylet can work. But if your distance from the mitral orifice, the septal puncture site distance is far away, then of course you have to take a curve which is bigger. And if the site is closer to the mitral orifice, you have to take a tighter curve. All of us know. But here we a curve side right not and we don't know what is he trying to make what as you're trying to make so been crossing 12. Now another very important thing is most of us talk about curve 4 centimeters. So we are talking about only 2 planes. Well, most of the structures have 3 planes. What I mean is that can be given and the third plane can this case, not is easy, not once you get from LLV. So remember that sometimes you have to add extra curve. Now sometimes you just inflate balloon, your wire will walk in and your balloon will to walk and with let it walk down straight.
Ali Raza,
Yes.
can you tell the speaker to just show his slides and we'll try to make sense of it because we're in a stalemate.
This is the slide, Abdullah.
This is it?
This is it.
Okay, there are no more slides?
I think they have got few, but I think they've got some issues with the
Yes,
internet.
I just need to share slides, right?
Yeah, just tell him to go through the slides. We can't hear him, at least.
Are the slides not being shared?
Yeah, we can see the slides, but it's stuck at one point, so that's why it's on slide number 13.
I think we're going to go ahead to the next presentation. We're just getting connection with that. And
I think
there's a
This
problem on
is
their
being
side. not
live
on-
streamed and recorded.
Okay, I think
Full screen share while the other participant is sharing. Okay. So it's saying you cannot share screen while the other participant is doing.
Dr. Tehran, unfortunately, we are unable to hear you, so we have to move on. So we're going to go to the next one.
Yeah, I'm really sorry for that. That's an unexpected internet glitch from their side rather than ours. So the next topic which we are going to move on to is the fundamental of TAVR by Dr. Mohammad Raza from USA. So hopefully we will have a better connection this time.
So sorry about it. It is totally next.
Dr. Tehran, can you please stop screen sharing so we will then be able to connect?
Okay, so let me figure out if I know how to do the screen sharing. Can you guys hear me okay?
Dr. Raza, you are on. Go ahead, please. Can you hear us?
Hello.
Yeah, I hear you. How about you? Can you guys hear me?
Yes, we are ready. You can go ahead.
Hello.
This is
I'm
this is
gonna try
Bashir and Dr. Ali
to
Raza will
screen
be
share. Hold on
moderating.
one second.
So you can
Bashir.
share your screen and start, please.
Hi, can you guys see slide and can you guys hear me?
Yeah, we can see you and we can hear you as well. If you could kindly start screen sharing so we'll be able to.
I thought I did the screen share.
Yeah, we
No?
can see it now.
Okay, all right, very good. All right, well, let me see if I can go on PowerPoint mode right there. All right, so Bismillahirrahmanirrahim, Assalamu alaikum to everyone, and thank you for the opportunity, Bashir and the rest of the organizing committee. I'm going to go over a few of the fundamentals of transcatheter aortic valve replacement. These are my disclosures, nothing relevant to my talk. This is a little outline. I'll quickly go over the indications and heart team concept, and then a little bit on TAVR workup, some embolic protection, durability of the valve, and how do we do post-procedure care. As you all know, at this point in 2023, the preferred approach for the management of aortic valve stenosis is transcatheter aortic valve replacement. And it's there's a lot of data behind it, many trials, as many of you are aware. The devices has also improved. Now we are working on third and fourth generation valves. The profile has improved, lower risk of stroke. Vast majority of the patient we can do transfemoral. And some of the Achilles tendons early on in our experience was paravalvular leak and stuff like that, which has significantly improved or completely gone away almost because of the newer valves, the design and the skirts the newer valves have. And so is demonstrated overall events, death, stroke, heart attack, and rehospitalization, also significantly lower with the newer generation devices and even better than the surgical valve or surgical therapy. So no question that it has significantly moved along. So the indications of transcatheter aortic valve replacement, as everybody knows, is severe symptomatic aortic valve stenosis, and that's very clear, which means that the mean gradient is above 40, and patient has symptoms of dyspnea, chest discomfort, or loss of consciousness. But we have also indications in symptomatic patients. So if someone has a critical aortic valve stenosis with a mean gradient of about 50, or if LV dysfunction is present in the face of aortic valve stenosis, and some of the high-risk features of ETT positive with either ST segment deviation or drop in blood pressure. So in asymptomatic patient, there is also a criteria to pull the trigger and replace the valve if need be. For symptomatic, it's no-brainer. So how do we do it? The idea of heart team concept, you are well aware. One of the best byproduct of TAVR procedure is the heart team approach, which really is an amazing experience for people who are involved, and that includes the interventional cardiologist, cardiothoracic surgeon, the imaging people, whether they're echocardiographers or CT imagers, and our anesthesia department, the OR, the cath lab, and still, every Wednesday morning we have TAVR meeting. It's a lot of fun. We learn from each other, and we continue to improve and evolve. So I think this idea of heart team, and it's actually the backbone of transcatheter valve repairs or replacement in general, but obviously for the TAVR. What are the devices out in the market right now? This is on the top is the balloon expandable Sapiens valve. This is the older version, Sapien 3. But this is made up of cobalt chromium. There is a skirt inside and outside, and the outer skirt is now about 10 millimeters, and that decreases the risk of paravalvular leak. There are also larger cells on the top to get coronary access. Okay, this is the sheath that it comes with, and on the top, I think you guys can see it. Also one of the best sheaths that has come across over last several years is the E-sheath. Very hydrophilic, easily slides through tortuous vessels. And then we have a flexible system that decreases the risk of stroke and improves the delivery of the valve at the aortic valve annulus. That's the balloon expandable valve. This is self-expanding valve. There's a skirt here about 13 millimeter long. This is the commissural tab. This is the commissural tab we try to avoid aligning with the coronary blood vessels. Again, a little larger cells to get back into the coronaries. And now we have, this is an Evolute FX system. There are radiopaque markers on the bottom for commissural alignment. And the system is also improved now. The FX system has one spine instead of two spines, so the deployment is a lot more coaxial. Also, the nose cone is longer, so the delivery through the femoral access is much more smoother, and so is through the valve. So definitely significant improvement in regards to delivery of these devices. TAVR workup is pretty common. You all know. I'll skip some of that in the interest of time. So the echo, the cardiac cath, CAD, and PCI only we do in major epicardial vessels. The branch vessels in general, we leave it alone. So DIACs, OMs, PDAs, don't have to PCI before TAVR. In general, obviously, it can change based on the patient symptoms. CT is the default imaging strategy. Sometimes we do TE also for imaging for high creatinine, and MR we have used also. But we do our best at hydrating patient and getting a CTA done that gets the best imaging and resolution of the aortic root dimensions. Holter monitoring, sometimes we do if there's underlying conduction abnormalities, dental clearance. This is pretty standard. We used to do PFTs, curved Dopplers, right heart caths, along with the left heart cath. It's all gone away as a routine procedure. Procedural planning. Once the decision has been made to proceed
Sorry to just remind that
the vascular access comes.
You've got 2 minutes left, Dr. Raza.
Is the first major thing we go through. So 95+%, actually I would say even 98% are all transfemoral, and then we have percutaneous axillary or transcable cases, which we end up doing here and there, but vast majority is transfemoral. Careful review of the vascular access, the size of common femoral artery. As far as the size is above 5 millimeter, in general, you're okay to go through femoral artery. And then based on this size of the vessel, the tortuosity, you have, you pick the valve based on that, some of that at least, and also what kind of wire you're gonna pick. Okay, so vascular access, once that is clear, then the aortic root anatomy, what are the basics of aortic root anatomy? The leaflet calcification, annular size, alveoli size, sinus size, STJ height and calcium, and coronary height. These are the major things you want to look for in every aortic root anatomy before a TAVR procedure. This is a quick case that to give you guys a little mental break. Here it's morning. I know you guys been through the conference all day there. This is a patient, 66 years old, critical aortic valve stenosis. You can see his gradient is about 70. And he's pretty asymptomatic despite those gradients. This is his CAT scan. This is annular measurement, the area, the perimeter, the sinuses. This is bicuspid anatomy. I'll skip because there's another talk on bicuspid valve. This is a embolic protection device, Sentinel. We have been doing it 50 to 60% of times in patients, although this has decreased use since the protected TAVR trial. the patient, because of the bicuspid anatomy and heavy calcification in general, for self-expanding valve, we do BAV on almost all patients. And the valve is being deployed and post-dilated. This patient is now about 4 years later. You can see that his mean gradient is about single digits from mean gradient of 70. So he's doing extremely well. He's back to running and jogging and everything. What are other things that can come across while you review the root anatomy is a small aortic annulus or small aortic root. You can see everything is a little smaller. The sinuses are small, and so is the SDJ. And the coronary height here is borderline. So what do we do in this kind of situation when there is borderline coronary height and small aortic valve sinuses? And that's the idea of coronary protection. So you can see in this case, we have the valve there. We have a wire in the coronary, and there's a guide liner that fills the coronaries. At the end of the procedure, we have a stent ready to go. In case there's a coronary occlusion, we deploy the stent. Okay, this question comes up frequently. Well, from the patients in particular, well, how do the TAVR valves fare in the long run? We have up to about 8 years of data, and it shows that the TAVR valve is a superior valve in regards to hemodynamics and structural valve degeneration compared to a surgical valve. So, so far so good. We can confidently tell our patients that TAVR valve hemodynamics and the durability is very, very good in the long run. Post-procedure, last slide. Minimalist TAVR approach for the procedure, that's where we do radial and groin access. If there's sentinel, obviously, then we do both groins, but otherwise radial and groin. We are shifting all of our TAVRs to cath lab, obviously slowly, low risk, then to high risk. We do conscious sedation, and I mentioned radial femoral approach, limited echo intra-procedurally. We do MCOTs, or monitoring next day discharge, and we're looking into actually same day discharge, but there's some insurance-related issues. But next day discharge, 100% of our patients, as far as there's no issues, they go home next morning. And follow up 1 week, 1 month, and 1 year. 1 month follow-up echo, and 1 year and yearly echoes after that. And thank you very much.
Thank you so much for being on time, sir. Thank you so much. I think we've got Dr. Farkad Alamgir with his talk being uploaded now. And I think he's going to present in a bit. So while we're getting the slides ready, is there any question or any from anyone for Dr. Raza? Okay. Okay, sir. So I've got a question for you, sir. It's Ali Raza here. So I just want to ask that because I know there's a lot of SAPIEN being done in US. And I know we've got a talk coming up on the bicuspid as well. What's the proportion of the bicuspid valves that you guys do in US on the Asian populations? And
yeah, so great questions. First of all, first thing on the SAPIEN. My personal experience, we do approximately 50-50 self-expanding and SAPIENs. There are other centers that do 80% SAPIENs, and the other centers actually they do predominantly self-expanding. So it's both, but you're right. In general, the market is more favorable for, SAPIEN than Evolut. In regards to bicuspid, I mean, that's I skipped that only because, as you know, it's a pretty involved topic. We frequently do bicuspid and have been doing, and the case I showed you is 4 or 5 years ago, even before the low risk was approved. So, if you look at the TVT database, there is 30% patients had bicuspid anatomy, and they had favorable outcomes. So how often? I guess we do it all the times, bicuspid anatomy. Then what valve you use for bicuspid anatomy, and we have gone both ways. If we do SAPIEN, we tend to undersize the valve. So let's say the valve measurements come between 26 and 29, we will lean towards undersizing to 26 because of the risk of root rupture. If we are using self-expanding, then obviously we don't need to undersize And this is and this is one reason I lean more towards self-expanding in bicuspid anatomy. But there's so many factors in bicuspid. What kind of bicuspid it is, where the calcification is the raphe heavily calcified or a little bit calcified? The case I showed you is not as much calcified of raphe. We have seen worse. So we use a self-expanding valve. So you could go either way, but you have to understand that bicuspid anatomy still needs more due diligence than the tricuspid anatomy.
Thank you so much. I think we've got one other question, and then I will request Asad to take over and introduce the next speaker as well. And thank you so much for your very good presentation and lovely talk.
Just one question here. How would you proceed with anticoagulation in these newer generation valves, especially if there are PCI along with that? Patient is having a PCI, so DAPT and anticoagulation.
So, that is that's outstanding and very practical question. This is, again, we deal every day. In general, as you know, the trial has clearly shown that routine PCI before TAVR is not a good idea, because many of these patients are elderly, and if you do the PCI, as you said, the patient is going to be an aspirin Plavix or ticagrelor or whatever other antiplatelet. And what happens, they end up bleeding more often later on, right? So in general, if patient has no angina and there's no critical lesion in the epicardial vessels, we have stayed away from PCI before TAVR. So as I mentioned, DIAGs and OMs and PDAs, they could be easily managed with medical management. So if there's if there's a PCI has been done for whatever reason, then obviously DAPT has to be done, But if there's no PCI done, then we only use aspirin after the newer generation valves.